Hello, I'm Matthew Cooper, Director of Kidney and Pancreas Transplantation at MedStar Georgetown Transplant Institute and Professor of Surgery at Georgetown University School of Medicine in Washington, D.C. Today we'll be exploring management of patients following living donor kidney transplant, and more specifically, we'll be taking a closer look at the treatment burden associated with chronic immunosuppression, which is the post-transplant standard of care. As you know, available treatment options today for patients with end-stage renal disease are limited to transplant and dialysis, and survival probabilities between these options differ. Transplant has been shown to provide lower long-term mortality risk and higher health-related quality of life compared with dialysis. Patient survival probabilities in the United States are more than 2 times higher at 10 years with kidney transplant versus dialysis. In addition to patient survival, graft survival is a critically important outcome. The national data show longer estimated graft half-life and higher median graft survival rates with living donor kidneys compared with those from deceased donors, indicating a potential graft survival benefit with living donor kidney transplant. And despite our efforts and successes in improving one-year outcomes in kidney transplant, long-term graft survival has not increased substantially in the last 20 years. Currently, about 1 in 3 living donor kidney recipients will require a second kidney transplant within 10 years. For those of us in the transplant community, one of the major concerns without a doubt is rejection, which accounts for 17% of graft losses in the first year and 63% of losses thereafter. While chronic immunosuppression therapy represented a major investment in transplant by mitigating rejection risk, adherence is paramount. Importantly, studies have shown that kidney transplant recipients who are non-adherent to their immunosuppressive regimens are 7 times more likely to experience graft rejection or loss. In the United States, more than 90% of kidney transplant recipients are maintained on a calcineurin inhibitor, or CNI, based immunosuppression regimen. KDIGO guidelines recommend maintenance therapy with a CNI and an anti-proliferative agent, with or without corticosteroids, beginning prior to or immediately after transplant. Immunosuppression may be reduced 2 to 4 months after transplant if no acute rejection has occurred. In particular, since CNIs can have nephrotoxic effects, minimizing or eliminating their use is an important consideration in balancing the potential increased risk of acute rejection with reduction of side effects. In CNI-sparing, or CNI-free immunosuppression regimens that include mammalian target of rapamycin, or mTOR inhibitors, or belatacept are used in some carefully selected patients. When CNIs are used, each dose can cause renal hypoperfusion due to the vasoconstrictive effects on the preglomerular afferent arteriole. Continuous CNI-induced renal hypoperfusion can ultimately lead to chronic changes in the kidney. CNI-related histologic injury in allografts is characterized by obliterative arteriopathy or hyalinosis of the afferent arteriole, ischemic collapse or glomerular scarring, tubule vacuolization, focal interstitial fibrosis associated with macrophage influx, and tubular atrophy. And many of these chronic changes may become permanent. So how common is this damage? Studies show that CNI-mediated histologic injury can be seen on biopsy in most patients using CNIs at some point after transplant. In fact, the single-center study of 119 patients who underwent kidney transplant between 1987 and 2000, all protocol biopsy samples showed signs of CNI nephrotoxicity at 10 years. Patients in this study were maintained on triple immunosuppression with cyclosporin or tacrolimus, plus prednisolone plus azathioprine or mycophenolate mofetil. In addition to CNI nephrotoxicity, chronic post-transplant immunosuppression is associated with a number of other health risks, including metabolic syndrome, cardiovascular disease, neurotoxicity, serious infections, and malignancies. Let's look at each of these conditions in greater detail. Immunosuppression therapy contributes to metabolic syndrome conditions, which are risk factors for cardiovascular disease. Cardiovascular disease is a leading cause of death for kidney transplant recipients with a functioning graft. Risk of graft loss is also increased by more than 3 times in patients with post-transplant hypertension and more than 2 times in patients with post-transplant diabetes. Post-transplant diabetes has been reported in 10 to 74% of kidney transplant recipients. About 1 in 3 transplant recipients experiences neurologic complications, most often due to immunosuppression-related neurotoxicity. Neurotoxicity may be mild, for example, tremor, neuralgia, and peripheral neuropathy, or it may be severe, including slurred speech, vision loss, seizures, cerebellar ataxia, psychoses, and hallucinations. Infection is a leading cause of complications post-transplant. The estimated rate of post-transplant infections is 45 per 100 patient years. Common infections occurring more than 6 months after transplant include pneumonia, viral respiratory infections, and urinary tract infections. Patients who are chronically immunosuppressed may have a compromised vaccine response. Based on recent data, this could include vaccination against the COVID-19 virus. Immunosuppression increases the risk of malignancy, which is the third most common cause of death post-transplant. Squamous cell carcinoma, renal cell carcinoma, post-transplant lymphoproliferative disorders, and other cancers associated with viral infection are among the most frequent malignancies that may occur after kidney transplant. Risk of malignancy is more than 2 times greater at 10 or more years after transplant and in patients who were under 40 years of age at transplant. When you consider the impact of all the risks associated with chronic immunosuppression, the need for an alternative approach to preventing graft rejection becomes evident. What's more, there are effects that extend beyond these clinical implications that are important to consider. Chronic immunosuppression can impose practical and financial burdens on patients and increase the risk of drug-drug interactions. Transplant recipients generally need to take 15 to 25 pills a day for the rest of their lives, and the medication regimen after transplant can be particularly complex for patients who require additional medications to manage comorbidities related to chronic immunosuppression, such as diabetes and dyslipidemia. In a single-center study, 94% of kidney transplant recipients were taking at least 5 different medications a day, which is known as polypharmacy, and 38% were taking at least 10 medications per day. Aside from immunosuppressants, prescriptions for cardiovascular medications are most common in kidney transplant recipients. Notably, immunosuppressants can interact with other commonly prescribed drugs, such as antibiotics, antifungals, and calcium channel blockers through CYP3A or P-glycoprotein inhibition or induction, or other interactions. These interactions can affect immunosuppression efficacy by increasing or decreasing serum concentrations of immunosuppressants. So as I've just discussed, chronic immunosuppression in the kidney transplant population has the potential for clinical repercussions, but may also impact quality of life in transplant recipients. In a small study conducted at Massachusetts General Hospital, kidney transplant recipients who achieved long-term immunosuppression-free allograft survival through human leukocyte antigen, or HLA, haplotype-matched combined kidney and bone marrow transplant required significantly less medication for hypertension compared with patients who were chronically immunosuppressed and did not develop diabetes requiring insulin therapy, dyslipidemia, or malignancies. Patients in this study who were immunosuppression-free also scored higher on assessments of physical quality of life using the Kidney Disease Quality of Life Short Form 36 survey. Another study in kidney transplant recipients showed that poor functional status and depression were associated with lower rates of treatment adherence. The outcomes and risks we've just seen underscore the limitations of standard of care immunosuppression, while highlighting the need for advances in transplant that may offer our patients a chance for longer and healthier lives. Thank you for your time and your commitment to kidney transplant.